Well, thank you, Dr. Freed. What I'm going to cover in this section is what I describe as new insights into the physiology and treatment of hyperkalemia. So just by way of background, remember in a typical 70 kilogram individual, we have roughly 3,500 milliequivalents of potassium. Most of that potassium is in cells, primarily skeletal muscle. And we have about 70 milliequivalents in the extracellular fluid. And it's this large inward to outward gradient that determines the cell voltage. And this is why disturbances in serum potassium give rise to manifestations primarily in excitable tissues like the cardiac tissue and neuromuscular tissue. Just an overview of potassium homeostasis. Consider somebody ingesting 100 milliequivalents of potassium. As you well know, the kidney is primarily responsible for excreting that potassium, but do be aware that the colon also plays a contributory role. And as we lose kidney function, the colon starts to assume a much greater role in total body K homeostasis. And in fact, by the time you reach dialysis, it's estimated that about half of potassium that's secreted from the body is occurring in the colon, perhaps accounting for the occasional observation that a dialysis patient who has undergone colectomy actually has more problems with hyperkalemia. Now, it turns out that the kidney's ability to excrete a potassium load is a little bit sluggish. It takes about 4 or 5 hours following ingestion. So in order to guard against excessive rises in the extracellular concentration, there's a shift initially under the influence of insulin to move potassium into the cell to allow now the kidney enough time to reestablish total body K balance. So the two most important factors that play a role in the internal distribution are in fact insulin. Insulin not only functions to regulate glucose, but as I say, it shifts potassium into cell under normal circumstances. The other major regulator is beta-2 stimulation, and this has relevance in the setting of exertion. When we exert, a small amount of potassium comes from the skeletal muscle cell into the interstitial compartment, and that exerts a vasodilating effect. At the same time, we activate the autonomic nervous system when we exert ourselves, and by stimulating beta-2 receptors, that keeps that potassium exiting in check. It's regulated. And this phenomena may explain why, for example, in the setting of total body K depletion, we know that that's a risk factor for rhabdomyolysis. It may be due to skeletal muscle ischemia because there's not enough potassium to exert that vasodilating effect in the interstitium of skeletal muscle tissue. So remember that potassium in the kidney, it's freely filtered across the glomerulus. It's largely reabsorbed in the proximal tubule in the thick ascending limb. And it's the component that's secreted in the distal nephron that varies and is tightly regulated. The primary cell in the collecting duct that's involved in potassium secretion is the principal cell. And you can see that the epithelial sodium channel, the ROM-K channel on the apical surface, the NAK-ATPase on the basolateral surface. The alpha intercalated cell also plays a contributory role where potassium is reabsorbed on the HK-ATPase, but this probably only has relevance under conditions of hypokalemia where this HK-ATPase is upregulated. The primary determinants of K secretion are mineralocorticoid activity, distal delivery of sodium, and flow rates. And shown here is the important relationship that mineralocorticoids and distal sodium delivery have on potassium secretion. Remember, one of the major factors that influences potassium secretion is mineralocorticoid-induced sodium reabsorption through that epithelial sodium channel, creating the negative charge, providing this driving force for K secretion. So things that will enhance potassium secretion are going to be maneuvers that enhance distal sodium delivery and also high flow rates. High flow rates will dilute the luminal potassium concentration, providing a more favorable gradient for secretion into the tubular lumen, but also recall that high flow rates bring out another channel that's present in the collecting duct, the so-called maxi-K or BK channel. So high sodium delivery, high flow, important determinants of renal potassium secretion in the distal nephron. Now, I want you to be aware that the normal kidney actually has a very large capacity to excrete potassium and maintain a normal serum K concentration. And to illustrate that are these 5 studies. And I want you to just compare the baseline and the final diet. These were studies designed to challenge the kidney and to see if you could induce, in essence, hyperkalemia. And notice that in these people who have normal kidneys with really profound increases in dietary potassium, the serum potassiums are quite normal. So in other words, the kidney does have a very large capacity to excrete potassium. Some older studies suggest that when we ingest increasing amounts of potassium, some of that potassium is recycled in the medulla, it accumulates in the interstitial compartments, and that exerts an inhibitory effect on salt transport in the thick ascending limb, once again providing more flow and salt delivery to the potassium secretory sites. There's also some older data to show that potassium that accumulates around the proximal tubule may also have inhibitory effects on salt transport, once again providing more delivery to be able to handle a potassium load. But you have to ask yourself, if you were relying on inhibiting salt transport in the thick limb and the proximal tubule, these high capacity segments, that might not have the precision necessary to ensure that you had just enough sodium reaching the distal nephron to maximize K secretion and not be excessive and predispose one to volume depletion. And so to reconcile that dilemma, people have turned their attention to the distal nephron itself. And there's really recent data to show that the distal nephron possesses an intrinsic potassium sensing capability. And that's illustrated on this drawing. So the idea is, in the distal convoluted tubule, you'll recall, it's now divided into two segments. The DCT1, which has no aldosterone sensitivity, and this is where the thiazide sodium chloride sensitive transporter is. The DCT2, the second part of the distal convoluted tubule, is where aldosterone sensitivity begins, and this is where electrogenic sodium reabsorption also begins, and then that phenomena extends into the collecting duct. So the idea is that with an increase in dietary potassium and a slight increase in your extracellular K concentration, even within the normal range, is sensed by this DCT1 and leads to a slight depolarization of that cell. With the cell interior now being slightly more positive, this will prevent chloride from exiting the cell with a net effect of causing an increase in chloride concentration. And it's been observed, and there's experimental evidence to suggest that a high chloride signals the WNK, the with-no-lysine kinase family of proteins, and their downstream mediators, SPAC and OCR, to exert an inhibitory effect on the thiazide-sensitive sodium chloride transporter. As a result, sodium is now delivered to the electrogenic DCT2, where, again, potassium can be secreted, and also the flow is increased to allow more potassium to be secreted by the maxi-K channel. In other words, notice how now the process is regionalized, and this is all due to a direct sensor that exists in this particular segment. So again, just to summarize, increased K intake seems to, at that DCT1, signal a pathway that inhibits thiazide-sensitive sodium chloride transport, thereby in a regional fashion providing more sodium delivery to cause potassium secretion. At the same time, subtle rises in extracellular K may also stimulate aldosterone, and that's going to facilitate this process because aldosterone obviously stimulates ENaC, thereby contributing to the negative charge. And also, interestingly, aldosterone has a direct effect not only on ROM-K, but also the maxi-K channel as well. This potassium sensing capability of the distal nephron may actually occur independent of changes in mineralocorticoid. One can show that in a rodent model. If you take an animal and knock out its ability to make aldosterone, notice that as you increase the dietary potassium content, the serum K concentration stays fine until you get to a very high potassium intake. Once again, suggesting that the tubule cells itself are modulated in response to the subtle rises in the extracellular K concentration. And there's a human correlate to this, and that is a normal person who happens to have hypertension on an ACE or an ARB. As you know, in the setting of normal renal function, hyperkalemia is distinctly unusual. And here in these 20 ACE or ARB treated subjects, normal renal function, you markedly increase their K intake, and yet they maintain a normal serum potassium. Again, could it be because the distal nephron itself is sensing subtle changes in the K and even independent of aldosterone in this regional fashion, leading to augmented K secretion? Again, to support the idea that the human has a large capacity to excrete potassium is the idea that we initiate the K secretory process immediately as potassium enters into the gastrointestinal tract. In fact, there's data now to show that as potassium enters into the stomach, this leads to a very quick dephosphorylation of the sodium chloride cotransporter in that DCT1 segment, initiating the increase in renal K secretion even before there's any change in the blood mineralocorticoid. In other words, a gastric renal sensing mechanism. And a nice human study to illustrate this is shown here. A group of normal subjects were given a 35 millimole potassium meal, and then in the setting of an aldosterone blockade, and notice how urinary K markedly increases. There's no demonstrable change in the serum potassium, and this is in the setting of a mineralocorticoid blocker, once again suggesting that the K secretory mechanism is being initiated over and above any change in mineralocorticoid, perhaps due to this intrinsic sensing capability of the distal nephron. So again, just to summarize, the normal kidney has a prodigious capacity to excrete dietary K. It's initiated as potassium enters into the gastrointestinal tract. We have this intrinsic sensing capacity within the distal nephron, and then we combine that with these older observations of more upstream inhibitory effects. We can see that perhaps the normal design of the kidney was to handle large K loads. So you may ask, why does the kidney possess a large capacity for renal potassium secretion? Well, it turns out that if you look at prehistoric man, it's been estimated that they ingested nearly fourfold higher potassium intake than what we ingest today, about 15,000 milligrams potassium per day. With the onset of agriculture about 10,000 years ago, there's been a progressive decline in dietary K intake, and that's been associated with a number of diseases. In fact, the most recent dietary guidelines published in January of this year said that potassium is a nutrient of public concern due to inadequate consumption, and that inadequate consumption of potassium may be linked to a variety of cardiovascular diseases to include hypertension, stroke, osteoporosis, and nephrolithiasis. And at the same time, in our chronic kidney disease population, we tell them to restrict their dietary potassium. Are we doing, in fact, a bad thing? Well, obviously the reason we do that is our patients have a lot of reasons to develop hyperkalemia. This is a slide I've shown in this type of form many times before, but patients are receiving a variety of medications that interfere in the renin-angiotensin system. They have decreased numbers of nephrons, so they're prone to hyperkalemia, and so that's why we restrict dietary K. But I ask the question, if hyperkalemia could be prevented, are there benefits of a diet that, like fruits and vegetables, that happen to be enriched in potassium? Might that be a benefit to a CKD patient? And there's a number of observations that suggest that might in fact be the case. So are there benefits? Well, yes. First, there's decreased gastrointestinal absorption of phosphate when you ingest plant protein as compared to animal protein. Just think about your dialysis patients. We always encourage them to increase their dietary protein. But one of the consequences of that is it can worsen hyperphosphatemia, particularly animal protein. But interestingly, for the same amount of protein intake, if you give it as plant protein, you can actually get reductions in the serum phosphate. There's less phosphate absorption with plant protein. This is shown here. If you go from a 35% plant-based diet to a 70% plant-based diet, notice how urinary phosphate goes down, reflecting decreased phosphate absorption. And if you go to a 100% plant-based diet, urinary phosphate fell even further in these studies. So again, this would be a way to augment our protein intake in a dialysis patient without, for example, worsening hyperphosphatemia. Remember, plant protein contains phytates. Those phytates bind phosphate, they don't relinquish them. That's one of the reasons. Also, animal protein is typically enriched, as you know, with sodium triphosphate for preservation and flavoring. That makes animal protein even worse. In addition to decreased absorption of phosphate, a diet enriched in vegetables and fruits is an alkaline load. It could contribute to control of metabolic acidosis. So here's a study of 108 stage 3 CKD patients who were randomized either to usual care or sodium bicarbonate tablets or a diet enriched in fruit and vegetables. And notice the change in GFR over this 3-year period. Here's the usual care having a faster rate of decline, and the two approaches designed to correct or maintain a normal acid-base status, less decline, and one of the arms is fruits and vegetables, a non-pharmacologic therapy. Interestingly, if you look at a 14-year follow-up of these participants in the NHANES 3 survey, patients who had chronic kidney disease, at least based on dietary recall, those who have a greater acid intake, a dietary, animal protein intake, they have a higher rate of developing end-stage renal disease as compared to those who eat a less of an acid ash diet. Once again, fruits and vegetables is an alkaline load, recall. In an observational study of 623 patients with type 2 diabetes who started off with normal renal function and followed over an 11-year period, higher urinary potassium excretion was associated with a slower decline in renal function and a lower incidence of cardiovascular complications. In the PREVENT study, you may recall this is a study in Europe, much like the Framingham type of study, where you take a cohort of individuals and look at a variety of health measures over a 10-year period. They got periodic 24-hour urines to assess dietary K intake. Chronic kidney disease had developed in about 872 of these individuals, and what they found was there was no relationship to dietary sodium in the risk for development of chronic kidney disease, but those individuals who had higher urinary potassiums had less chronic kidney disease development, whether measured by both a decline in eGFR or urinary microalbuminuria, or either one of the components alone. Once again, suggesting a benefit of a diet that happens to also contain a lot of potassium. And lastly, a diet with a higher proportion of protein from plant sources was associated with lower mortality in patients with chronic kidney disease here in the NHANES 3 participants. Once again, notice how plant protein goes up. The mortality in this cohort of patients with CKD was improved. So just to summarize then, I want you to be aware that the normal kidney has a very large capacity to excrete dietary K. The distal convoluted tubule, there's emerging evidence that the distal convoluted tubule acts as a renal K sensor. Interventional trials are clearly needed to determine whether increasing dietary K would be of benefit in our chronic kidney disease population. And if it were, strategies to limit the development of hyperkalemia in this population at risk for hyperkalemia would clearly be of clinical utility. So thank you very much for your attention.